Good morning, everyone. My name is Yasiru, and my topic is oncology care in Sri Lanka, advancing radiotherapy and training for the future. Sri Lanka, with the land area, it's about Bangladesh about 2.3 times bigger than Sri Lanka, and with the population, it's 21 million compared to the 169 million population in Bangladesh. So, brief geographical distribution, you can see the population density in Sri Lanka is mainly centered around the capital, Colombo. And when we see the poverty map, the most poorest areas are in the north and east. I work in a teaching hospital in the east of the country. So health system in Sri Lanka, it's predominantly a public funded state health system, free at the point of delivery, and all the funding is by the general taxation. And there's a coexisting private healthcare as well, mostly funded by out-of-pocket treatment. Sometimes now increasingly, uh, health insurance schemes are utilized more. Uh, Health expenditure is 4% of the GDP. So cancer is the second leading cause of death, and you can see it's behind the cardiovascular diseases. And number of cases are expected to increase with the prevailing data. These are some data from the cancer incidence. So you can see some significance in the oropharyngeal cancer when we compare with the world data, and I think it's very common to the region as well. There's in the males there's a prevalence of oral cancer, and in the females you can see that incident data of CS cervix still in the 6%, and when if we compare the mortality data, it would be more higher. So oncology workforce in Sri Lanka, currently it's 42 clinical oncologists, 4 hematologists and 3 pediatric oncologists, alongside with the 18 surgical oncologists. We have 20 medical physicists and 80 radiographers, and we need increased workforce for the fight the increasing cancer burden. And unfortunately, due to the economic situation, some of the clinical oncologists has migrated, and these numbers were expected to be like around 60, but due to the situation, still at 42 with the struggling oncologists. So these are the radiation facilities in Sri Lanka. Sri Lanka divided into 9 provinces, and 7 provinces has radiation facilities with the 5 units with the linear accelerators, and 2 still uses cobalt machines. And 2 afterloader brachytherapy machines are there, one in Colombo and one in Central Kandy. And there's 25 medical oncology centers throughout the country. Every single administrative district has a medical oncology clinic. So these all cobalt machines were installed in 1980 to 1990, 10 in total, and most of them are decommissioned, and 2 of them will be decommissioned this year. Little bit about the National Cancer Institute in Sri Lanka. It's one of the largest in the region with the 15,000 patients referred annually and 1,000 bed capacity. It has 4 pediatric units and 10 adult medical and clinical oncology units and 4 oncology units. It gets referral from all part of the country. This is the pictures of the National Cancer Institute. It's called Apeksha Hospital, which means hope in English. These are the workhorse of the National Cancer Institute, the cobalt machines. So treatment delivery by the cobalt is now increasingly used for the palliative treatment, for metastatic spinal cord compression, whole brain treatment, and sometimes due to the workload, with the locally advanced head and neck cancer, we use field-based treatment. And sometimes the cervical cancer, we used box plan for the cobalt treatment. And most of the chest wall radiotherapy done with the cobalt machines. Sometimes we use 2D planning for the head and neck cancers and the palliative treatment. So cobalt treatment is very simple. We used to prescribe in a paper. This is a uh, cobalt treatment order form. You can see that we were manually writing the field sizes and the marking is done manually. So one of the mark X-rays. So to verify the treatment, we use X-rays in the cobalt machine. These are some other pictures of the palliative treatment we are giving with the cobalt machines. This is a simple 2D plan, radiotherapy plan, which is we give it to the cobalt machine. In 2010, Ministry of Health decided to replace all the cobalt with the Linux due to the age of the cobalt machine, and it's very costly to maintain the source of the cobalt, and the obviously the inaccuracy of the treatment, and cobalt doesn't have IMRT or SRS treatment. So the first linear accelerator was into operation in 2009, and it is almost in a decommissioned state now. The second LINAC in the country, which has the cone beam CT facility. So this electrosynergy machine in operation. So treatment delivery using the LINACs, now we have 5 centers with LINAC. Mostly we used IMRT. VMAT was commissioned recently in the National Cancer Institute, but it's very difficult to plan the treatment due to the time and the less number of people specialize in that. So, and the VMAT is available only in one machine. So we have another 3 machines with single energy, which we cannot commission for the VMAT. And we also have commission for SBRT for lung, but it's very challenging due to the 4D CTs imaging and the motion management technique. Or a few radiographers have only specialized in this uh, treatment. So for annually, it's about 4 to 5 patients get treated with the SBRT. So the challenges with the linear accelerators is increased number of patients. We treat up to 80, which is not the standard, and the maintenance of machine is difficult. Cost is very high, 40 million per one machine, and sometimes there are some planned and unplanned downtime with the Linux. So it will affect the patients because we don't have synchronous machine or backup machines to provide the continuous radiotherapy. And we have 2 intracavitary brachytherapy machines. One is providing cervical cancer treatment with the, and sometimes we use very rarely interstitial brachytherapy machines. It's a brachytherapy machine using Manchester system. So medical education, so we have a board certification in clinical oncology. All the physicians are clinical oncologists. After 1 year of postgraduate from the internship, you can sit for the selection examination with the 150 medicine MCQs and 150 oncology MCQs. We will select about 7 to 10 candidates. Then after training in lectures in physics, radiobiology, pharmacology, cancer biology, statistics, and pathology, they sit for the part 1 examination. And then there's a 2-year registrar period with the 8 rotations in 6 clinical oncology, hemato-oncology, and pediatric oncology rotations. Then they set for the part 2 examination, and then we do another 1 year in senior registrar period in locally, and another 2 years training fellowship in the overseas. That's a 1 year mandatory requirement for the before becoming a board certified consultant. So after board certification with the portfolio viva, we become a clinical oncologist. So college has the PGIM has collaboration with the RCR to provide the foreign examiners for the both part 1 and part 2 examinations. So for the future, in conclusion, when we compare the need analysis, we need training programs for the oncologists, physicists, and radiographers to obviously to provide the more radiotherapy service to the patients. And there's a very important in integrating the emerging technology for the AI, adaptive radiotherapy, and SABE, and increase local training slots for the radiographers. And roadmap for the future and expand infrastructure, adapt molecular diagnostic, and strengthen the multidisciplinary care. So my email, and thank you.